pleasure having you here, everyone, and it's my honor to be here and to speak about this topic that's very close to my heart. So we're just going to start with a big picture, interrupt, and ask me any questions you want at any time, okay? So don't feel shy. So we're going to start talking about breast cancer in young women, but we can talk about any topic related to breast cancer in women in general. So in young women, breast cancer is usually very aggressive. It's a little bit different than the breast cancer that presents in women post-menopause. And there are a lot of psychological distress associated with diagnosis of breast cancer across all ages. So that the most important one is the fear. Women can experience isolation, lack of information, which can lead to increased fear, body image issues, which are actually correlated with age as well. The younger the age, the higher the body image-related problems and psychological distress that women experience. Childcare and job-related chores that can be affected after the diagnosis of breast cancer, as well as fertility, risk of fertility with the chemotherapy that a lot of patients end up receiving, as well as getting pregnant after breast cancer. Those can be questions. Those are commonly questions for women who are diagnosed at a young age with breast cancer, as well as breast cancer during or right after pregnancy. And that's a topic that is not talked about very often. I can answer your questions about that. I'm not going to talk specifically about this topic, but it's very relevant to young women with breast cancer, as well as genetic risks. So for today, we're going to talk briefly about breast cancer diagnosis and treatment and side effects of therapy. Your loved ones may be experiencing these side effects, and we can talk about how you can help with helping them through the journey. Fertility concerns is metastatic breast cancer, and I will touch upon the genetics at diagnosis of breast cancer as well. Welcome, welcome. Breast cancer. General statistics, is very common. It's the most common cancer in women. And luckily, it is not the most common cause of death from cancer in women because a lot of women do survive their breast cancer diagnosis. A lot of women remain at risk of cancer returning. So the window, unfortunately, a lot of times never closes. But we do have a lot of women with breast cancer, and we do have a lot of women who are survivors of breast cancer, and that trend is going to increase in years to come. And what is breast cancer? How does it develop? Just want to have a simple picture diagram over here for you. So the breast tissue is made up of mostly fibroglandular tissue, which makes the milk. The milk drains into the milk duct and comes out through the nipple. And these are the white projections that you can see coming from the nipple. The rest of the breast is fat tissue. But as like any organ in breast, the lymphatic fluid drains to the lymph nodes. There are lymph nodes over here, the internal mammary. There are lymph nodes over here, the axillary, and right up here. So essentially a lymph node chain. And what happens is, over time, there are many risk factors for breast cancer, and sometimes we don't actually know what causes it. But what happens inside the milk duct can start getting thicker, multiple layers of cell. And as the cells grow, they get out of control. They can have mutations in them. And at some point, unfortunately, the mutation gives the cell the ability to get out of where it is, and that's what happens with invasive breast cancer. It leaves the area it first developed in, and a lot of times it can go anywhere. Initially, it will go to the lymph nodes because that's where the lymphatics drain it. They drain the cancer cells and they go into the lymph node, and that's where initially the breast cancer cells go. Yes?
On your first graph, it showed men and women, prostate and breast were the highest two of those. Is there something about those two tissues that tend to have the highest number of cancers?
So, very good question. So what happens in the breast tissue for a woman, start developing during puberty. So initially the breast, so these lobules have not developed in a child, and during puberty they start developing, and they change with every menstruation cycle. So during a menstruation cycle they initially grow, then they sort of dissolve. So there's a lot of changes at each menstruation cycle, and there's a lot of time, since puberty, every woman is exposed to estrogen and men are exposed to testosterone, and most of the tumors that develop are essentially cells that initially were normal, responding to these hormone levels, given that there is always essentially a growth factor available to them. And then sometimes they get out of control. The reason for the strongest theory out there for why it's so common is because of the prolonged exposure in our lifetime to a growth factor for the tumor. But why are their rates of cancers increasing in general? That's a different question, and maybe we can get into that later.
I have a question. Do you think that's because of more birth control use?
There is some data about birth control, and that's a good question. Initially, data was not conclusive. There is some recent data that was presented in San Antonio in December that with prolonged use, usually more than 10 years, there is about 20 to 30% increased risk of developing breast cancer immediately after stopping the birth control pills. And they've been reported that sometimes, not generally always, but sometimes women who are on birth control pills and develop the breast cancer, their breast cancer may be more aggressive. But data is still coming in, so.
I noticed my wife, she has two other sisters,
Mm-hmm.
and her and my other sister use birth control, but her younger sister didn't, and she doesn't have the problems that my wife and her other sister has.
Mm-hmm.
So I'm thinking maybe because of birth control.
So there are a lot of, there are new research is coming in. Birth controls have been around, but not for 100 years. So maybe in the future we have more conclusive data, but what we have right now is a long period of use, consistent use, has been associated with a small risk. So diagnostic studies, usually mammogram is the first study that gets done. Can be limited in young women because in young women, in the breast, there is a lot of fibroglandular tissues and less fat. And mammogram essentially detects thick tissue and the underlying fat. So it's usually used best in women who do not have very dense breasts, generally not younger women. Ultrasound, it can easily detect solid or cystic lesions, and it's usually preferred in younger women, but not for screening. Screening usually starts with mammogram. MRIs are very good. They're very expensive. They're very sensitive, but unfortunately, they're not specific. What that means is it can pick up something that looks very odd and strange, and it can alarm people, but it may end up being nothing, but it can create a whole lot of fear. Okay, it can pick up whatever there is, and it may not necessarily be cancer. So generally, after breast cancer is diagnosed, I, as an oncologist, look at three main things, and that's when I talk to my patients, going over these three, and I tell them this breast cancer falls under this category. So first thing, staging. It's very important if the cancer is invasive, so not a tumor that hasn't, broken through its wall. A tumor that's not invasive, if it hasn't broken through its wall, then that's stage 0. But otherwise, we look at tumor based on how large a tumor is, whether it has already gone to the lymph node, as well as whether it has already gone to any other organs. That would be stage 4 metastatic. Then we look at histology. Most common kinds of breast cancers are the invasive ductal carcinoma. And those are the ducts that connect the milk ducts that connect the lobules to the nipple. Less common is invasive lobular carcinoma, is about, maximum 10% of all breast cancers. And there are other kinds that are, again, minority, like papillary, mucinous or medullary carcinomas, they're more rare. Then we look at the receptor status. So what I want you to take away from this picture is breast cancer can be ER/PR positive like this. It can be ER/PR positive and HER2 positive, or it can be ER/PR negative, HER2 positive, or ER/PR negative, HER2 negative. So when it is ER/PR negative, HER2 negative, it's called triple negative breast cancer. If it's HER2 positive, this usually takes precedence at diagnosis. HER2 positive breast cancer used to be one of the most aggressive breast cancers, but nowadays we have excellent treatment for it. And usually better, slower growing, best prognosis, ER/PR positive breast cancers. General treatment, big picture, local therapy or systemic therapy. Local is usually involves surgery. In rare cases, we can omit surgery, but in most cases, we do take out the tumor, and that's called the lumpectomy. In other words, segmental mastectomy, and that always requires radiation. If we do mastectomy, and there are many reasons for that, sometimes we do radiation, sometimes we don't, and that depends on how large the tumor is and if there are many lymph nodes involved with the tumor. Systemic therapy is a changing landscape. A lot of women will end up receiving hormone therapy because estrogen receptor positive and progesterone receptor positive, the ER/PR positive, the hormone positive breast cancers are the most common. Chemotherapy, a subset of patients receive chemotherapy. Again, a subset of patients receive targeted therapy. As I was speaking about the HER2 positive tumors, those are the ones that need targeted therapy, and we'll go in more detail on that. And immunotherapy is the new kid on the block. So after diagnosis and pretreatment, what are some of the tests that we do? Some women may need CAT scan or PET scan or MRIs to find out if cancer has gone to any other organ. So that's called screening for metastatic breast cancer. A lot of patients will need a lymph node biopsy, especially if the tumor has been diagnosed as being invasive, and that includes most patients. We need to do laboratory testing to find out if the liver is functioning all right, if the kidney is doing its job well, because that can determine what kind of treatment we can give later on, and an echocardiogram, and that's how good the heart is functioning. If the heart is doing its job really well, we know that standard therapy would be good enough, and if the heart is not functioning as its best, then we need to alter the treatment. Fertility discussion and assessment in young women, as well as genetic testing. So now, your loved one may be diagnosed with breast cancer. How can you help? How can you help them? It's a very challenging place to be. Of course, they're the ones going through the trauma of the diagnosis. Most of the time, what they're looking for is, a lot of times, a listening ear, compassion, but also a helping hand, because a lot of things in life may be challenged at that point. Career may need to be on pause. Someone needs to pick the kids up from school. Who does the grocery shopping? So a lot of things can be affected that way. So being aware of that and being there during the process, most of the time the process of diagnosis and treatment is temporary. It doesn't last forever. That can be different for patients who have metastatic breast cancer. A lot of times those patients are considered to have chronic disease, and they will need to continue treatment for a long time, and their health may wax and wane. It's very important that the loved ones, their support group, are in tune with what's happening to them. So genetics, usually in young women, so the guidelines are, which are going to change. The guidelines are currently, if a woman has triple negative breast cancer, as long as they're younger than age 60, they can get genetic testing, because those genes, BRCA1, BRCA2, and PALB2, there are a myriad of other genes that are not as prevalent, can be associated with their breast cancer. if someone is diagnosed to carry one of these genes, and you may have heard that in the news, then things can be done to prevent cancer from returning. That includes bilateral mastectomy or removing the breast that is not affected, as well as a lot of times removing the ovaries as well, because those can be at risk of developing cancer as well. And larger implication, the family members need to know so they can start preventive measures.
Is LB2, is that a receptor like BRCA1, BRCA2?
It's very similar. It's in the same complex. Yeah. Or it's called homologous recombination complex, yeah. There are a myriad of other genes, so ATM. Yes, those can work the same. So for women who still desire pregnancy after diagnosis of breast cancer and treatment, treatments are temporary. They're not going to last forever. So for those women who haven't been pregnant or desire to get pregnant later, we offer either ovarian suppression, which is usually, if it's sort of we're in a tight spot and we need to start treatment, usually we go with ovarian suppression, and that puts the ovaries to sleep. So when ovaries are sleeping, the theory is if they get chemotherapy kills cells that are growing really fast. So if there are eggs that are developing, growing fast, if they get chemotherapy exposure, they will just die. So if we put them to sleep, they're not going to develop. They're just going to not be affected with chemotherapy. And there is some data showing that it does actually help preserve the ovarian function after completion of chemotherapy. If we are not pressed for time, and I tell you that's not very common, we can do egg retrieval and also embryo harvesting. There are some risks associated with that because women end up receiving a lot of hormones, and if they have hormone receptor positive breast cancer, that can make us concerned a little bit. But they're out there. So treatments. So there is not a one-size-fits-all. Things change. Things are different for everyone, essentially. Big picture-wise, if the tumor is very large and we can't do surgery, and that includes any tumor, usually over 2 to 3 centimeters, we would like to shrink it down and have the best cosmetic result with the surgery. So what we do neoadjuvant therapy. Most of the hospitals in the US use neoadjuvant chemotherapy. Certain places like MD Anderson and Baylor, we use a lot of neoadjuvant hormone therapy, which has less side effect than chemotherapy and a lot of times work well. A lot of centers are also starting to use that mode. If the patient is willing to undergo just surgery up front, if the tumor is small enough, we can just do the surgery up front. Then a lot of times we need to use adjuvant chemotherapy, or hormone therapy, which is post-operation. Radiation needs to happen if anybody has a lumpectomy, if the patient has a lumpectomy for an invasive cancer. And in certain situations, we do radiation after a mastectomy, and that's usually tumors 5 centimeters or larger, usually more than 4 lymph nodes that are involved. So mastectomy essentially removes the whole breast. It used to be radical mastectomy in the past 50 years ago. They used to remove the whole breast, remove the muscle under it. Sometimes they remove the muscle under that one, pectoralis major, minor, very debilitating surgery. Essentially only the skin and the rib cages would remain. But now, thankfully, we've realized we don't need to do that. It's too much. We could just remove the breast, and really the practice is our neoadjuvant therapies have become so good that most of the time we don't have to do mastectomy. But there are always cases that that's necessary. So reconstruction, sometimes immediately, sometimes after radiation. Again, it depends on the stage and the breast cancer subtype. And sometimes after the surgery, women can experience pain in their chest because there can be some nerve damage when they do the resection, or the skin can be numb. And I see that very, very commonly. There are some good things that we can use for that, so massaging the area. Sometimes acupuncture can be used, yes?
Is that on the side of the
Usually,
culture, Because my wife had a double and she has pain on the one
that didn't have.
did not have.
So there's a cutaneous nerve that unfortunately can be damaged during the surgery. Chelsea and I were just talking about sometimes some surgeons try to save that nerve, but it's very difficult, and it's not my area, so I can't tell you the detail, but it can happen. So if double mastectomy, there is a risk associated with just surgery in general. So it doesn't have to. The side effects from the mastectomy are not necessarily related to the tumor itself while it was there. Lumpectomy, more commonly used these days. So it only removes the tumor and the surrounding environment of the tumor, or tumor environment. And sometimes if the pathologists find that the margin is positive, they will have to go back and re-resect, and that happens. We see that often. We do radiation after lumpectomy almost always. The outcomes are the same. Mastectomy without radiation versus lumpectomy with radiation, they have the same outcome in terms of risk of recurrence. So if we can save the breast, we do that.
Do you do it on older women? Do you usually do the radiation after lumpectomy, even if they're older than 60?
Very good question. So there are two studies. There is a Swedish study, and there was a trial called Prime 2 that has shown that when women age over 65, it used to be 70, but we have data now, 65 is okay too, to omit the radiation, especially if they're diagnosed with ER-positive breast cancer and they don't have many lymph nodes involved, then we can, their life, it's just not going to come back.
Do you really think that doing a lumpectomy radiation versus doing a double mastectomy, same outcome recurrence? I got an argument with my oncologist about that. Because, the data shows it, but it just doesn't make sense. If you remove more tissue, then it's a less of a chance of it reoccurring because you're removing most of the tissue. This doesn't,
So I understand, and believe me, a lot of my patients ask that from me, and they diagnosed with stage 1, T1, T2, tumor like 4 centimeter, they would like both of the breasts removed, so the risk of cancer returning is 0 or none.
That's what we did. Hers was like the top pinhead. And even to remove both breasts and all the tissue, there was nothing else in there.
Yeah.
What protected it,
So, no, that's a very good point, and it sort of makes sense to think that way. But, there are still some things about cancer that we don't have our a finger on. We don't really know exactly how a lot of things happen. But what we do know is that even with the mastectomy, bilateral mastectomy, the chance of cancer recurrence is not 0. And in the studies, if we do radiation to the breast, so radiation kills tumor cells that might have been left behind and they're dividing fast, radiation kills them. So given that, in the long run, if a woman has had bilateral mastectomy, but she could have had a lumpectomy with radiation, most of the time they have the same outcome.
But also, if it's a genetic issue, you do radiation, damage healthy DNA of cells, then it's like you can cause secondary tumor family.
So there was some data for ATM gene mutation that radiation, if somebody gets breast cancer in one breast, doesn't want to remove the other breast, what's the risk of radiation to this breast causing cancer to the other breast? The radiation techniques have become really good so that there is not a lot of refraction to the other breast that's not affected. So nowadays, we recommend if you want to continue with just screening mammograms and MRI, we do that. It used to be different, 20, 30 years ago, though. So we're just getting better. Okay.
And it also depends on the age. I know we're in a young conference, but percentage of the survivor is also, then the doctors look at that and say maybe radiation isn't the way to go. Maybe double mastectomy isn't the way to go because of the outcome. They can't handle it.
That's a very good point. Radiation is not risk-free. It can cause burning. Over years, actually, it can cause some tissue damage that radiation acts over time. So that can happen. And if it's not improving someone's survival, we better not give it. So with low-risk cancers in older women, why should we put them through that? That said, they used to do that, though.
Yeah.
But nowadays, we know that that's too much. So what's sentinel lymph node? That was, we discussed that briefly. So depending on the location that the tumor is, it drains into a lymph node. So that drainage used to be present for the normal tissue. Now there's tumor, so it's draining the tumor cells into the lymph node. Sentinel lymph node is essentially the first lymph nodes that the tumor drains into. So if we remove those and there's no cancer in them, excellent. There probably isn't cancer anywhere else. But if we remove those and there's cancer in them, there may be cancers in other lymph nodes. So we have to look for more lymph nodes. Again, the treatment for that is, the approach to that is changing. We have data showing that we can remove just a couple lymph nodes, and if there's cancer in one or two, then we just radiate that area. We don't need to go ahead and remove all the lymph nodes, which is called axial lymph node dissection, which used to be common practice, and a lot now we're able to actually do less and get better outcomes. Just do radiation instead of removing all the lymph nodes. So, as I was talking to you about just now, sentinel lymph node evaluation, it can lead to axial lymph node dissection. Sometimes, with added radiation, the area in the axilla can be very fibrosed and very damaged. So what happens is lymphedema. Lymphedema can happen within the first year of breast cancer diagnosis or happen years later. But that's essentially the damage to the lymphatic drainage. And it can be debilitating. What we do these days is mostly physical therapy, but there are some surgical procedures that are being tested, and maybe in a few years we have better approach. So radiation therapy kills any cancer cells that may have been left behind. It's usually 5 days a week for 4 to 6 weeks. Now we have accelerated radiation, or we can have actually a new therapy is also leaving the radiation catheters inside the tumor bed after the tumor is removed, and women can go home and just come back a few days later and have it taken out. So there are options out there. Standard practice is still the radiation to the breast over a few weeks, every day. Can cause skin radiation, burning, fatigue. It used to be associated with a lot of heart disease because the techniques weren't good enough, so that if the cancer was on the left side, it was radiating a lot to the heart, and that can cause vasculature damage of the heart. But nowadays, things are much better. There can be some long-term complications, and I would really like for anyone who's received radiation to the breast be aware of this. If what's called angiosarcoma, it can happen in the skin that has been radiated, and it's essentially an aggressive tumor. It usually starts with a rash or red rash, and it can develop into a big lump that's protruding through the breast or through the skin area that was radiated. So,
Is that super common?
oh, it's absolutely not common.
Okay.
It's extremely rare.
Here's clients the minute they get around.
Oh, yes. It's just it would be good to know, because if it's diagnosed early, things can be done. But if not, it can be very bad. So, not common. So systemic therapy, that includes usually the chemotherapy. Doctors usually they will go over all the potential side effects, and most of the time patients take home their education booklet home and they can read about it. And it's very good if a loved one or friend or family is available, is present with the patient when the doctor is going over the chemo side effects. It's usually a whole lot of stuff that's being talked about, and it's really hard to remember everything. So generally, chemotherapies can cause infection, nausea, vomiting, diarrhea. Some of them can cause mouth ulcers. Some of them can cause rash or urinary tract infection, bladder infections. Some of them that we use commonly in breast cancer can cause heart failure. And in the long run, again, very rare, secondary cancers. Targeted therapy for HER2-positive breast cancer, we have these available. So HER2-positive breast cancer essentially has this receptor on its surface that tells the cell to grow. So what we do, we block them with antibodies. So that's what those are, trastuzumab, pertuzumab, and a new one is TDM1. So those blocks that receptor, so that tells the cell don't grow. We have those same receptors on the heart muscles, the myocardium. So that's why when these agents are used, patients can get heart failure, usually reversible. And ultrasound of the heart needs to be done every 3 months. Endocrine therapy, so most common kind of breast cancer is ER/PR positive. It grows in response to hormones. We block the hormones. Cancers don't grow. Patients do well in terms of, cancer cure and lower risk of recurrence. However, that comes with a lot of different side effects because estrogen is good for us. So if estrogen is not around, there are some things that can happen with the, osteoporosis, mood changes, and the risk of uterine cancer with tamoxifen. So if a woman is taking tamoxifen, they would really need to, if they have any vaginal bleeding, they will need to let their doctors know. Sexual function is, again, affected because of the hormone therapy that patients end up receiving. That can also be a psychological component, body image related issues. And sometimes we use some antidepressants to help with symptoms of hot flashes, and that can also affect the sexual dysfunction. And what we recommend is, talk to your doctor about it. There are ways around it. Exercise is a good thing, but we do have non-hormonal, vaginal creams that can be used. Pregnancy after breast cancer, actually 10% of breast cancer survivors can become pregnant, and the risk of recurrence of the breast cancer is not related to the kind of breast cancer that they had. Because the concern is if they have estrogen receptor positive breast cancer, if they get pregnant, increased hormones, is the cancer going to come back? And we don't see that happening. What we do recommend is definitely wait and get pregnant. Try to get pregnant after 2 years of completing after 2 years of at least 2 years of hormone therapy. If it's triple negative, 2 years after diagnosis. Give your body about 2 years. Going back to work, having family responsibilities and body image. Those are very difficult things for a lot of women after a big trauma. It's a huge trauma to receive the diagnosis of breast cancer. So is there anything that it can do? So we do have data that exercising is a great thing. Sometimes it can be difficult to exercise if the chemo has resulted in neuropathy, but we do recommend 30 minutes, 5 days a week, if you can do it. Raise your heart rate, do something. Walking is great, but maybe running is good. Maybe go to the gym if you can. That can also, has been associated with lowering the risk of cancer recurrence. It's also very good for the heart.
My wife is on tamoxifen currently, and anytime she gets really going and starts sweating, she has a chance of getting sick. And the last few times she's gotten sick, we've ended up having to go to the hospital because she kind of can't fight it. What would you suggest would be something easy to work out to help?
She gets sick how?
Her immune system is really low, so she'll start sweating, and it's like she gets a cold, but it hits her a lot harder, and it's
So maybe she can talk to her doctor about Effexor that can help with, so it sounds like there is some dysregulation with temperature management of, in the hypothalamus. So sometimes Effexor can help with that. That's something that I use often for patients. Metastatic breast cancer, of course, patients can be diagnosed with stage 4. Sometimes the breast mass is very small, but by the time we diagnose it, it's gone to other organs. Or years later, after the initial breast cancer diagnosis, it can come back and be stage 4. So it is by no means a death sentence, in and of itself. We have a lot of good treatments available. A lot of women live a very long time. Some people go into remission, and I can tell you that I see it often. So, but what happens is most of the time, patients need to receive treatment chronically. So we look at it as a chronic disease. The treatments that they receive, again, depends on the subtype and where the tumor is, or whether there is any organ that's at risk of failure. So chemotherapies, hormone therapies. Now we have immunotherapy as well available. Sometimes we do radiation. Sometimes we do surgery. Not often, but sometimes we do that. And what we always encourage our patients is to get on a clinical trial, because clinical trials are testing something that we think may be better than what's out there. Sometimes there's nothing out there. And sometimes there's a standard care out there that causes a lot of symptoms and side effects, and maybe it doesn't work very well. There are always new drugs coming into the market. And all patients, I encourage everyone to ask about whether there's any clinical trial available for them. That's how we got all of these new drugs. So again, the hardest challenge is for the patient with metastatic breast cancer, but family is affected as well, for sure. So communication is really important. Going to maybe, the patients need to go to a communication workshop to be able to be there for each other and not feel guilty if they ask a question that, they fear maybe their partner is going to misunderstand. And again, communicate with your physicians, because a lot of times there are good support groups and behavioral therapies that we could use. So everyone has different needs, and communication is just really, really important. I can't emphasize that more. And have, for friends, it's good to actually be there with practical support, because someone undergoing therapy with neuropathy may not be able to do a certain thing that really affects their quality of life, and you could be there for them, and that's what they need. And then treatments are coming, into the market every day, and we never know. The landscape may change in 5 years. There can be, things on the market that are not here today. So keeping hope and loving each other is very important. Okay. That's it. Questions?
How do they treat neuropathy? How is neuropathy treated?
Neuropathy.
Yes.
Okay, very good question. Big problem for a lot of our patients. Tons of our chemotherapies that kill the cancer kill the nerves. So we do have some good treatments out there. So Lyrica, gabapentin, these are medications to stabilize the nerve and sort of keep it calm, because the nerve can be damaged, and damaged nerve send constant signals. So duloxetine is a good drug if nothing else works. Acupuncture sometimes can be very helpful. There is some data out there about acupuncture. You need to be careful if someone has had a mastectomy and lymph nodes are removed, or radiation to the axilla. They should be careful with getting acupuncture in that arm. But generally, it's been shown to be effective in calming those nerves.
are there any specific physicians that can deal with this, or just?
So sometimes pain and palliative doctors would be good to go to. If there is one in the practice of your oncologist, they can make referrals, and they can play around with the regimens that we have available to find what works best for someone. Yeah,
Massages?
massage is good. I had a mentor who actually was recommending to patients to massage the area with a warm towel, and I've recommended that to some of my patients, and they actually find relief. It's mostly from the neuropathy, from the breast surgery, the mastectomy site, or post-lumpectomy with pain in the breast or the axillary area. And I've recommended that, and they've liked that. The massage is definitely very good for, it's sort of like physical therapy for lymphedema to help drain the lymphatic tissue, and that helps. Mm-hmm. I have a question.
I was wondering just, why can't you give acupuncture or any shots or anything on the arm that you had all the lymph nodes removed from?
Yeah, again, very, very good question. So the risk is that if there is any damage to the integrity of the skin, bacteria can get introduced to the skin. And what fights the bacteria is our immune system, which is usually housed within the lymphatic tissue and the lymph nodes. So if the lymph nodes are gone, the immune system in that area is not functioning as it should, and if the fluid can be drained back, so that the lymph, the serum that's diffusing off the blood, if it can't be drained back to the circulation, it just gives bacteria a good niche to just hang on and infect the area. So it's better to do that. But there is some data actually that maybe we're being a little too cautious about this. So sometimes women don't want to have, if they've had like 1 or 2 lymph nodes, sentinel lymph nodes removed, and they haven't had radiation, a lot of times women become very scared of anything happening to that arm. And the risk of lymphedema is not 100%. So, it's less than 50% a lot of times. So it's good to re-educate patients as well.
I'm glad that you said that about the lymphedema, because I think in your on in the conversation you said it could take up to maybe a year or so before it develops.
Mm-hmm.
And is that because I know that the lymph nodes have been removed, but is it because it takes that long for the fluid to build up, or what exactly is happening here?
So yeah, it does take a while for fluid to build up. Sometimes if, lifting heavy things with an arm, what it does, it dilates the artery. A lot of blood comes in. Not all the blood comes out because, it diffuses out to the tissue. So not everything goes back into the vein to be drained back. So some of it stays around. And over time, it can build up. So that's why it's good if somebody, if a patient has had their lymph nodes resected or radiation to that area, both of them, or even one of them, there is damage to the integrity of the lymphatic chain. So they just can't drain the fluid as efficiently. So massage, what it does, it contracts the tissue around it, pushes the fluid back into the circulation. It can happen over time, because one of the other reasons is radiation acts over time. So if somebody has had radiation to the arm, axilla, it may not cause tissue damage and fibrosis immediately, but it can work over months or sometimes years. We see like the skin keeps changing, and that can cause further damage to the lymphatic system.
Is there something you can do to prevent
Lymphedema?
lymphedema? Is there anything that you can do before so it doesn't get to that?
Yeah, this pre-massaging.
Don't do a whole lot of heavy lifting. I usually send a lot of my patients to lymphedema therapy. And
My wife got this big suit that she gets to wear that kind of moves it all around for her too.
the lymphedema clinic
prescribed.
does it.
And when she does lymphatic massage every 2-3 days.
Yeah. Prevention is the best.
the lymphatic surgery after, you say you send your patients to have therapy?
Lymphedema clinic. I send to lymphedema clinic, which is a physical therapy. The surgeries, if you're asking about like lymphatic tissue transplant,
No.
there's some.
My question is, you said you usually refer your patients to that clinic or what have you. At what point do you do that? Is it after you've already noticed the incidence of the,
So what it can start with is edema of the mastectomy site. If we know that's going to happen there, it's only a matter of time to happen in the arm. It's good to send patients early on if they've had, radiation or axial lymph node dissection. So they know what. Sometimes patients get really scared. They think they have deep vein thrombosis or DVT in that arm. So that can be very scary to them if that's what they think they're having. But it's just a lot of times it's just lymphedema. So it's good to have patients educated on the topic early on.
Is any of that covered?
Yes.
It
Yeah.
is?
The suit that we got, insurance paid for it all, and the massages, insurance pays for it all. Like the doctor, or the guys were saying earlier, know your insurance, know what you can get, basically, and just, we have a great team up there in Dallas, and they fought for it. So my wife got it, it's all at home. Like, we don't have to go out, they come to us.
So that's great. Chelsea, you have a question?
So I was going to ask a question about genetic testing. Since I work with a lot of younger girls whose parents have it, and I still notice there's a huge need for more education and resources about, the genes that you can have. Also in LA, I'm actually Jewish, and a lot of people are Jewish. Do you have any thoughts or resources about the first thing someone can do to be tested if they don't want to go through 10 million steps, do all this stuff? There's more things now where you can do it at home and free. It's getting better, but I'm curious you can help with that.
So, it used to be so expensive to do the assays for those 40-something genes. It used to cost like over $12,000. So insurance was a lot of insurance companies were very unforgiving and who they would, support to get tested. But in the past few months, the cost of, because the assays have become so good, and the cost of a test has dropped to about $250. So a lot of times patients can just go to Invitae or MyRisk and request to have that tested, and they can just get tested. If they can afford $250 out of pocket, they can get tested. And there's a lot of there's potentially going to be a whole lot of changes in the guidelines. I'm just predicting based on the data that's coming out. I don't want to commit to saying this is definitely going to happen because I don't know. I'm not on board. But a recent study has been published that even with the current guidelines of testing women with hormone receptor positive breast cancer under age 45 or triple negative under age 60, we're missing a good number of patients who have one of these genetic mutations. And a lot of advocates are pushing for getting genetic testing, and I think I'm in support of that as well. Get genetic testing everyone at diagnosis of breast cancer, because we are testing everyone with metastatic breast cancer nowadays, and that's a very new thing as well, like maybe a year or so, and that's probably going to get into the guidelines, given that the test is not so costly anymore, and we can save women from getting ovarian cancer down the line or contralateral breast cancer. Why don't we do that? That's going to save a lot of costs for the healthcare in general. So I think that's where things are headed.
If you're a parent and doesn't have any genes, how important is it to get tested yourself? I hear it's like less than 1%, but then that's a big number. Still in genetics, or I don't know.
So then if the test is still going to be testing everything that was done for the parent, because we have different assays. I don't think we have, maximum we have 49 genes in the panel. So if there is no gene from that parent who's affected, it's pretty unlikely that somebody has a new mutation in utero that now they're affected, they just don't know. But in general, women or even men who've had family members, first-degree family members, especially, parents who've been diagnosed with breast cancer, especially if they were younger than 50, then they are at higher risk of getting breast cancer in general, and there are things we can do. So, for example, we have data on chemo prevention using anti-hormone therapy, one of the drugs, usually Tamoxifen. So for a few years, so that their risk of getting cancer is essentially halved by the end of the hormone therapy
So
use.
having 2 daughters, at what age would you begin to test your daughters or sons?
So 10 years
for
younger,
protective ability?
10 years younger than the age their closest relative was diagnosed with breast cancer. If the relative has had genetic testing, then most of the insurance companies, almost all of them, cover genetic testing for the child. So they could just get the genetic testing as well. If the genetic testing is positive in the relative, and if the testing is negative for your daughter, then they can just relax. But if they do have the genetic mutation, and usually it's not a very good idea. I don't think so, but I may be proven
Well, if it
wrong
wasn't
in
in
the
our
future.
family, it wasn't in her family, and she was negative for everything.
Okay, she was negative?
So would that mean your daughter has a less likely possibility of being negative also, or
Yes.
because the wife has it, now she didn't have it? Something changed within?
So your wife has genetic mutation, has genetic
No,
mutation?
she had,
Nothing?
was negative.
Then your daughters are, so I will explain this just in general. So they pass, so one chromosome comes from each parent, right? So if a parent had a mutation, then there's 50% chance in general that the other one of the children could have it. Now, if the parent did not have any mutation, there is no, it's not going to pass. There wasn't anything, unless in the very rare cases, some mutation happened when the embryo is growing, and there's and if it's in some other gene that we can't test, it's impossible to know really at this point, at least.
But since we don't know all the mutations,
We don't know all the mutations.
we do genetic testing to go into like a database
Yeah,
until when new tests come available.
that's what they're doing a lot of times, yeah. So all the companies that are doing the genetic testing, they do have their own databases. I don't know if they talk among each other or what, but a lot of times, so sometimes patients are diagnosed with variant of unknown significance, like VUS and some gene. And then like 10 years later, that VUS becomes pathogenic. They say, oh, we have now data saying that the mutation that we initially had, there are thousands of mutations in each gene. They can happen. Some of them cause cancer, some of them don't do anything. So it's hard to say whether the variant of unknown significance causes anything. So it will just come with population studies in years to come. And they do revamp their databases to see if, a certain mutation that was, we don't know they didn't know what it was doing, and now it's known to cause cancer. So they will let those families, they should ideally let the families know. I think most of the companies do that. I don't know if all of them do.
To me, it seems like you get cancer at such a young age, it has to be genetic, whether they don't know it or not, because generally we're not around an environment with still not to cause things like that. I can understand if an older person in their 60s, 70s get breast cancer. But when you get at a young age, like some conversation going on.
There is that, and there is also, not all genes show themselves at every generation. So there is a theory out there that's, population is changing, things in our environment are changing, some things are different, so that the gene that, wasn't expressing itself like 3 generations ago is now expressing itself and causing cancer. So sometimes, if a patient gets whatever cancer, colon cancer, let's say, and at age, 60, now their child is at risk of getting cancer maybe younger. That's why we recommend getting tested 10 years younger than the family was diagnosed, because sometimes the genes tend to do that. They express themselves in younger and younger ages.
speak to follow-up after all the treatment's done and what is recommended and how the doctor goes about trying to figure out how often to see the patient and what to look for, and counseling the patient on what to look for.
Yeah, so American College of Physicians, together with the NCCN, have come up with guidelines for breast cancer survivors. There are tons of things to look into. I haven't talked about that here, but I recently gave a talk about this. So usually patients follow up within the first 3 months after having completed everything. So if somebody is on hormone therapy, if they complete a chemo and now they're going to start hormone therapy, they start hormone therapy, they need to come back within 2 to 3 months to make sure that they're tolerating the treatment. If they was triple negative or HER2 positive and hormone negative, and they don't need any of those things, they usually come back every 3 months within the first year, then every 6 months for the next 4 years, so a total of 5 years. In our practice, we have patients with hormone receptor positive come back up to 10 years after diagnosis because we do know that that kind of breast cancer can return many years later. Sometimes we see triple negative and HER2 positive cancer return, recur within, after 5 years. They're just less common than the hormone receptor positive cancer. So the other things that patients are at risk of is osteoporosis, because chemotherapies and hormone therapies, essentially most of the therapies that we give to breast cancer patients can cause osteoporosis. And majority of the patients during their treatment can be very sedentary, so that can add to the osteoporosis. Things to look out for. So bone density is very important. If somebody has received anti-HER2 therapy, the ones I was talking about, Herceptin, pertuzumab, or TDM1, block that receptor on the cancer, but also block the receptor on the heart. So those patients would need to get Adjuvant. Within 3 months after completion, if there's something there, then repeat it again. And patients who have had anthracyclines, which is the other kind of chemotherapy that we use in breast cancer very frequently, they're at risk of heart failure, usually after completion of therapy, but that can happen also years later. Very, very important, it's risk of heart disease in general. Heart disease is the #1 killer of everyone, right? And cancer treatment, cancer by itself, and the social environmental issues that come with that, lack of exercise, sedentary life, dietary changes, that can also increase risk of heart disease. So exercising is great. If patients can exercise through therapy, even chemotherapy, we recommend that. A recent study came out this past in December in San Antonio, showing that breast cancer patients that were undergoing chemotherapy were put on a trial to exercise an hour to an hour and a half with serious, cardio, and most of them did that. I think maybe like 87% of patients, actually, I don't remember the exact number, but they completed the trial. They could exercise that much during therapy, and then after completion of therapy, they looked at their cardiac function. They were bright, and this was like nothing has happened. They were back to normal. Yeah, it's very important. We take it for granted, but if any patient can do anything.
In Ohio, there are a lot of great resources for programs 6 months after treatment that they do diet and exercise, and we have a lot of those resources around.
Oh, that's great. That's great.
In your cities and towns, Live Strong, we have Maple Tree Care Alliance where they're giving out exercise things that you can do at home, and I think it's a good hot topic.
Well, warm round of applause. Thank you so much, Ms. Monet. That was so helpful. We really appreciate your time, and we